Welcome back, everybody. We hope everybody enjoyed our program yesterday. It was certainly a wonderful event looking at motility disorders, achalasia, as well as our keynote address by Dr. Peter Karillis. I want to welcome everybody back to day 2 of MINT 2021, our foregut disease conference. Again, just a couple of quick housekeeping announcements. For those of you who are interested and eligible in CME, you can click on the link on the main page to get information about how to do that. For those of you having any audiovisual issues, any technical issues, there is a small green box at the bottom left corner of your screen where you can live chat, or you can also go to the resource section and email our colleagues in AV who will be on standby to help you out. We do encourage everybody to ask us questions and comments in the comment section. So please feel free to interact in that way. And we'll be more than happy to answer your questions in the allotted time frame. And again, we also encourage you to go to the exhibit section in the allotted break time, meet with our exhibitors who have been very helpful in putting this program together. I'm going to pass it off to Charu Pranjpe, my co-director.
Welcome again, Charu Pranjpe. I'm the co-director of the MINT Foregut Disease 21 CME program. And this is our second day. Welcome you all again. We have an exciting sort of agenda today. We have 2 main topics. One is the interventions for reflux, both medical and surgical, followed by interventions for gastroparesis, which is, as we know, a very common topic, both medical, endoscopic, and surgical interventions for that. And intertwined between these, we're going to have 2 exciting debates from both the medical side and the surgical side to talk about both aspects. So I'm sure you will enjoy that too. I want to welcome all the attendees, especially all the huge number of international attendees that we have on this forum. So thank you all for joining us. Please give us your comments and feedback so that we can make this course even better next time. With that short introduction, I will hand it over to Kumar, who's going to now introduce the first session and our first distinguished speaker.
Thank you, Dr. Pranjpe. So our first session today will be focused on management of reflux. This is called the minimally invasive course. And so we're going to start with very minimally invasive. Our first speaker is Dr. Judy Nee. She's coming from Beth Israel Hospital, where she's an assistant professor of medicine. She's a specialist in motility disorders and medical reflux management. So welcome, Dr. Nee. Thank you for joining us.
Great, thank you so much. Thanks to the organizers for inviting me. Today, I'm going to start off this section by talking about medical therapies for gastroesophageal reflux disease. And we all know that the star of this talk is really going to be proton pump inhibitors. But the star has kind of faded recently, as I've spent a lot of time with my patients talking about the long-term side effects of PPIs because of new data that shows us that potentially there are some side effects like chronic kidney disease, dementia, that may not be as positive as we had previously thought. So today what I'm going to be discussing in a short and sweet discussion is really about proton pump inhibitors, the pearls and pitfalls that we now know about PPIs, and then move on quickly toward adjunctive treatments that may help with gastroesophageal reflux disease, specifically from our major GI societies. So no discussion about the medical treatment of GERD would be complete without first talking about lifestyle modification, right? This is what I learned in medical school, in residency, and in fellowship. But these are from the recommendations from our major societies. Both the ACG and AGA recommend, number one, that you talk about weight loss for GERD patients who are overweight or have had recent weight gain. And this is especially true during COVID. I've had many patients come having gained some weight and then saying their reflux symptoms are worse. Head of the bed elevation and avoidance of meals 2 to 3 hours before bedtime is recommended for patients, but specifically those with more nocturnal acid reflux. And then I know after my talk, there's going to be a great discussion about diet and diet modification, but the routine global elimination of food that can trigger reflux, all the good things in life, chocolate, caffeine, alcohol, tobacco, acidic or spicy foods, it's actually not recommended for the treatment of GERD because of a low level of evidence. Of note, recently there was a prospective nurses' health study that actually looked at over 30,000 women and their intake of coffee, tea, soda, and actually found that this was associated and dose dependent with increased risk of reflux symptoms. But so while the major societies don't recommend talking about these, as physicians, we always bring this up with our patients about certain triggers. And this can include different triggers, so specific triggers to that patient, right? Again, this is based on low level of evidence, even though anecdotally we all recommend and do that. And then finally, small volume meals, taking in smaller consumption of meals may help with reflux disease, but is not recommended. But really the cornerstone of medical therapy is going to be acid suppression with medications. And what I'm bringing up here is that the PPI is the star of this show, right? If you have typical GERD symptoms like heartburn and regurgitation, it's recommended that you can do an empiric PPI trial. And that's an 8-week trial. That's a reasonable approach to confirm that this person actually has reflux. And if they say they've improved, then that increases your suspicion that they actually have true reflux. You can increase this to twice-a-day dosing if you're still symptomatic, or adjust the timing. And I'm just going to talk about that briefly in the next few slides. However, we all know that patients present with all kinds of other symptoms, not typical GERD symptoms. Those atypical symptoms like sore throat, cough, throat clearing, globus, have burning mouth syndrome for some of my patients. And the recommendation from our societies, again, is to test before you empirically treat. Again, with COVID, there's been some changes about what studies have been available to us. And sometimes we go towards empiric treatment still. But in terms of usual recommendations, you should definitely evaluate for acid burden, reflux burden prior to initiation of PPI for those atypical GERD symptoms. Currently in the US, there are 6 PPIs available, commercially available in the US. And here you can see the bioavailability, the liver metabolism, the excretion of each of these medications. The use of the PPIs has really been kind of caught with some of these idiosyncratic or very specialized, unique kind of properties, right? We have to, or we recommend that patients start it, the PPI at least 30 minutes or 60 minutes prior to the meal. You can increase it again to twice a day if there's just a partial response. But in the studies where patients go between one PPI to another, there's technically not supposed to be a difference in efficacy between one PPI or another, even though, again, anecdotally, we do that all the time. Patients may be titrated down to the lowest possible daily dose that permits control. And so again, in practice, I tell my patients, after you've been successfully controlled on your acid suppression, we then go down and then even consider, even if you need it, you consider holidays every few months or so, meaning a couple of weeks or longer off of the acid suppression to see if you actually need it. Many non-erosive reflux disease patients can also use short-term therapy for symptom recurrence instead of this continuous PPI therapy. And this kind of actually highlights or speaks to all of the side effects that have been discussed recently about the PPIs. And this is the crux of the issue. PPIs, now in my practice, when I discuss with patients, hey, why don't you try an empiric course of acid suppression? A patient will say to me now, well, what about the risk of dementia? And you didn't tell me about the kidney disease. A lot of the discussion is about the short-term and long-term side effects and all of this data now that has come out about these potential associations between PPI and things like increased risk for bone fractures or osteoporosis, right? Note that this was only shown in case control studies. Vitamin B12 deficiency, reduced efficacy of clopidogrel, Plavix therapy, dementia, chronic kidney disease. There was a recent article that actually showed that if you use PPI, it actually increased the risk of COVID infection, right? But the issue is that we have to be cautious, one, about the confounders and the weakness of that association. And note that prospective studies, so I have these two prospective studies, one where 18,000 patients with stable cardiovascular disease were randomly assigned to receive PPI, this pantoprazole 40 milligrams once daily versus placebo. And none of the concerns over 3 years were seen. So no osteoporosis during that time, any vitamin deficiencies, dementia, chronic kidney disease were seen. And in 2010, the Cogent trial showed no clinical interaction of cardiovascular events between those who were on both omeprazole and clopidogrel. The overall message is that PPIs are still safe, but the one thing I want to bring up is it's become a big concern for patients, and this discussion has to be had between the provider and the patient about, do you actually need the PPI? What are the short and long-term side effects? And then also times when you should be coming off of the PPI if you don't have symptoms and trialing off of it. Despite the fact that PPIs are highly effective, so it's 86% effective in the case of erosive esophagitis, we know that there are inadequate symptom response with the use of daily PPI. So that can occur in up to 40% of Gerd patients and is the most common issue that we face as gastroenterologists. And so one of the main kind of overarching ideas behind why this doesn't work, why the PPIs don't work, is really about the PPI itself, right? Is it non-compliance? The patient is not actually taking it, doesn't like those side effects, so is actually taking it once every few days. Improper timing, they're taking it after their meal. That's very common. Also, patients taking it right before they go to bed. Inadequate dosage. They're taking 20 milligrams as opposed to 40 milligrams. Inadequate delivery or bioavailability. They have different metabolism of these. But the other big component is really what we've discussed before, which is about an alternative diagnosis. Could they have functional GI disease, right? Could they have reflux disease, hypersensitive esophagus, or functional heartburn, or an alternative diagnosis like celiac disease, connective tissue disease, or even delayed gastric emptying. I'm going to bring up now, in 2019, Dr. Speckler and his group published an article through the VA system looking at patients at the VA who were PPI refractory. So they had heartburn symptoms that was not relieved by PPI. I'm bringing up this study not to talk about the results or whether or not surgery was superior to the medications, but more about the flow of patients and why people were excluded, and how interesting and how that sheds light to the issue of PPI and alternative diagnoses. So in this study, 366 patients were enrolled for heartburn, again, refractory to medical therapy. And all of them, they were on different PPIs, were then placed on omeprazole twice daily for 2 weeks. And if their symptoms persisted, then they underwent upper endoscopy with biopsies, manometry, pH impedance study while they were on the PPI. And in the end, almost 80% of patients were excluded. So the majority of patients actually were excluded because 27% had functional heartburn. So their heartburn was actually, their reflux was well controlled, and they didn't have symptoms that correlated with actual reflux. And 11% actually responded to the PPI twice a day. So just switching the omeprazole and then making sure that they took it at the appropriate time, and then it was twice daily, actually improved their symptoms. So this is just to suggest that when PPI does not work, it is important then to undergo some sort of workup. And this leads me now to then adjunctive treatments. So other treatments besides that star PPI that we've all talked about, right? So after an investigation of that acid burden, the ACG and the AGA then recommend that you can use the following medications. H2 blockers have been around for a long time, and PPI is superior in healing erosive esophagitis compared to H2 blockers. However, you can use an H2 blocker if patients are, very concerned about long-term side effects, and as long as it does help their symptoms. In practice, we also often add it prior to going to sleep, specifically in those with nighttime symptoms, in addition to the twice-a-day PPI. But the major societies recommend to us that you should watch out, because again, there could be tachyphylaxis and tolerance basically to this medication. Baclofen has also been used to decrease these transient lower relaxations of the LES and decrease reflux episodes. In practice, again, this is a GABA agonist that has a good physiologic effect. We know that it should work for this. You can dose it between 5 to 20 milligrams 3 times a day. But there are side effects, and that's usually what limits us, right? That there's dizziness, there can be constipation, somnolence. And again, in practice, I've seen people being placed on this when they haven't had evaluation. So it's tough for people to be on this with these potential side effects without knowing that they truly do have reflux and what the reason is that we have placed patients on it. What about agents that coat the esophagus, like Carafate, Gaviscon, right? And the ACG recommends that agents combining alginate with an antacid, like Gaviscon, can help with esophageal acid exposure in the postprandial period, specifically for that acid pocket that people talk about. But per ACG guidelines and based on the evidence, there's actually no role for Carafate. In this, in the Northeast, I find that we use Carafate more than Gaviscon, but it's in practice, people use both of these and treat them equally. Metaclopramide or Reglan is not recommended as a primary or adjunctive treatment for the treatment of Gerd. The ACG specifically recommends that workup is required. So generally what will happen is that in refractory GERD patients, if we are pursuing a gastric emptying study because of documented acid reflux, then that's reasonable to consider using that. But in the absence of that, it's not recommended to add this on. And then finally, tricyclic antidepressants. Tricyclic antidepressants are used by gastroenterologists, medical providers all the time for functional GI diseases. And in my world, patients with reflux hypersensitivity and functional heartburn, there are small studies where they've looked specifically at imipramine, for example, versus placebo. There's been no difference in symptoms in these small studies. But again, in practice, we use tricyclic antidepressants at low dosages and increase them progressively to try to help with reflux symptoms in those who don't have true reflux. So thank you so much. I'm just going to summarize by saying that PPIs are overall safe, they're effective, but you should talk to your patients about the long-term side effects. And this is the area where there's room for intervention, right? That the PPIs have failed and that is giving room for newer therapies. But consider that you should do some sort of evaluation prior to initiation of any adjunctive treatments, medical therapy, with evaluating the acid burden before you proceed to some of these treatments. Thank you so much.